PGT-M is available when someone has already had genetic testing and they know the very specific genetic cause. Then we can use PGT-M to make a test that could test embryos, really to determine if the embryos have inherited those genetic changes and are expected to be affected with that genetic condition, or has the embryo not inherited those genetic changes.
What are the most common things that people might be doing PGT-M testing for?
Hi, superhumans! I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Centre, otherwise known as our baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
On today's episode, we welcome back Diane Myles Reid, who is not only the president of the Canadian Association of Genetic Counsellors, but she's also the lead genetic counselor here at Markham Fertility Centre.
We are very happy to have you back. Today, we're going to be talking about pre-implantation genetic testing for monogenic conditions, and that's short for PGT-M. Diane, I know that you are an expert on this and you're so passionate about this topic. And it's not something that a lot of people know about, but more people really should know about it because it can have a significant impact in the health of your baby. So welcome, and let's get right into it.
Thank you. Thank you for having me back. I am excited to talk about PGT-M today. You're right. I'm so passionate about any test that can help people have the family and the babies that they're hoping to have.
PGT-M is such an interesting topic in the world of fertility because these are very often patients who don't have infertility, right? So, can you tell us what is PGT-M? If these patients don't have infertility, who is it for? Why are we doing this?
Absolutely. PGT-M refers to a test called pre-implantation genetic testing for monogenic conditions. And a monogenic condition is a single gene genetic condition. So PGT-M testing is really available for people who know that they have an increased risk to have a child with a very specific genetic condition.
And how would somebody know that they have that risk?
That's a great question. Sometimes an individual themselves may have a genetic condition. Perhaps they've been diagnosed with a condition themselves and they know that there's a chance to pass that condition on to any of their children. Sometimes people have a family history of a genetic condition and they learn that maybe they have an increased risk to have a child that's affected. Sometimes people may learn that they're a carrier for a genetic condition, for autosomal recessive conditions. If an individual and their partner are both carriers for the same genetic condition, then there is an increased chance to have a child affected. So most of the time, it's because an individual themselves or one of their family members has a specific genetic condition.
You used some genetics terminology there. What is a carrier? What does carrier mean?
Carrier is someone who has a genetic change. We use the word variant to refer to a genetic change. A carrier has one copy of their gene that has a genetic change, and then that gene cannot do what it's supposed to in the body. Carriers are healthy generally because we have two copies of each of our genes. And a carrier is someone that has one copy of the gene that's working as it should, and one copy of the gene that has a genetic change. But for carriers, usually they are healthy because that working copy of the gene is enough to function as it should within the body.
Can PGT-M detect anything and everything?
No, that's a great question. PGT-M is very specific for the condition that is in the family that's having testing. It's actually very specific to those variants or genetic changes that are present within the gene. One of the considerations with PGT-M is that there must already be a very clearly defined and clearly known genetic cause that has been identified in either the affected individual or the family members. So PGT-M is available when someone has already had genetic testing and they know the very specific genetic cause. Then we can use PGT-M to make a test that could test embryos, really to determine if the embryos have inherited those genetic changes and are expected to be affected with that genetic condition, or has the embryo not inherited those genetic changes and would be expected to be unaffected with that genetic condition.
A lot of patients ask about conditions like ADHD and autism when we're talking about genetic testing. Can you comment on that?
In general, I would say that PGT-M is not usually used to be testing for ADHD or autism. I think in most people and families where there's a diagnosis of autism, it's usually a very complex condition. So there can be many contributing factors, not usually one single gene cause. There are exceptions, I suppose. If there is a single genetic cause or there's been a genetic cause identified in the family, then, PGT-M may be able to test for that condition, but most of the time, autism is more of a complex trait where it's not related to one single gene change.
Can you give us some examples? Like, what are the most common things that people might be doing PGT-M testing for?
Yeah, for sure. So PGT-M testing can be used to test for hundreds of genetic conditions. It has been used to test for hundreds of genetic conditions, but some of the most common would be cystic fibrosis, spinal muscular atrophy, Fragile X syndrome, Huntington's disease, inherited cardiomyopathy or cardiac conditions, inherited cancer syndromes. I would say those are some of the most common.
We talked about this in the episode that we did on carrier screening, but can you refresh our memory in terms of for a baby to be affected, you need both the egg source and the sperm source to be the carrier of the same condition. So can you talk about that a little bit?
That's right. So for autosomal recessive conditions, there would be an increased chance to have a child that was affected with that condition if both the egg and sperm source were carriers for that same genetic condition. And, sometimes people have a child that's affected with an autosomal recessive condition. And then when they do testing, they learn that in fact they are carriers for that genetic condition. In that case, when both members of a couple or both egg and sperm sources are carriers for that same genetic condition, there would be a 1 in 4 chance in any embryo or in any pregnancy or child that both the egg and the sperm have passed on that genetic change and the child would not have a working copy of the gene. There's also a 3 out of 4 chance that a child would have either 1 or 2 copies of the gene that are working, and the child would either be a carrier or unaffected with that condition. When people are carriers for the same genetic condition, there's a 1 in 4 chance for having a child that's affected, a 3 out of 4 chance that a child would be the carrier and unaffected or unaffected with 2 normal copies of that gene.
For people who are listening to this podcast episode, I mean, a lot of the conditions that you name, they're really serious. And so let's say somebody doesn't have a specific family history of any of these conditions, but they're worried. What can they do? How do they go about potentially finding out if this is something they should worry about or if they should be considering PGT-M?
That's a great question. I think if someone doesn't have a family history of a known genetic condition, then they may opt to have carrier testing, to have carrier screening for those conditions that they could be a carrier for, but still be healthy. And so, expanded carrier screening is a genetic test that allows us to screen for hundreds of gene changes and can screen for hundreds of genetic conditions to know if someone is a carrier for a condition that they maybe wouldn't otherwise realize that they're a carrier for. And then on the other hand, some people do have a family history of a genetic condition, and individuals may seek a genetic counseling appointment to perhaps consider genetic testing to learn if they are at an increased risk to have a child affected with whatever the condition may be in their family.
Can we talk a little bit about the use of carrier testing in the context of donor and surrogacy, especially let's say you're using an egg donor or a sperm donor?
I think most donors have had genetic carrier screening. And so some people are selecting an egg or sperm donor that they know is a carrier for genetic conditions. And so carrier screening can be used to test oneself if they're using a donor. If someone is wanting to use a sperm donor, for example, and they want to test themselves to see if they are a carrier for the same conditions that the donor that they're considering is a carrier for. This information can be helpful to know that the donor that they would like to use does not present sort of a higher chance to have a child affected with a genetic condition. So carrier screening is often used when selecting a donor so that people can move forward knowing if there's an increased risk or if there's a low risk to have a child affected with a genetic condition.
Yeah, because to be clear, we're all curious of something, right? The question is, whether it's autosomal dominant or recessive. And if it is recessive, is the egg of the sperm that you're planning to conceive with, is that also carrying the same recessive condition? But everybody's carrying something around, right?
Absolutely. Yes. We're all probably carriers for, different studies will show different numbers, but maybe between 3 and 8 or 3 and 10 genetic conditions. With current technology, we don't have the ability to test for all genetic conditions. Usually, carrier screening is really focusing on those autosomal recessive conditions or X linked conditions. So, conditions where someone may be a carrier and healthy and not know that they're a carrier. For autosomal dominant conditions, many a time, someone would know that they are affected with an autosomal dominant condition because they might have symptoms of that condition. And for autosomal dominant conditions, if a person has an autosomal dominant condition, each of their children would have a half chance, a 50% chance to inherit that gene and would be at risk of having the symptoms related to that condition. So we don't think about being a carrier so much for autosomal dominant conditions. Usually you might know or you might have a family history of an autosomal dominant condition that would sort of prompt you to seek out genetic counseling. And for families where there is an autosomal dominant condition, again, PGT-M can be used to test their embryos to know ahead of time whether the embryo has inherited that genetic change and is expected to be affected with that condition or whether the embryo is expected to be unaffected. It really allows people to have that information before embarking on a pregnancy, allows people to minimize the chance to have a child that's affected with a genetic condition.
That makes sense. I've done a few PGT-M cases, but one that comes to mind, it's a couple where one of the parents had a condition where there's an increased risk of colon cancer. And he told me the story about like every member of his family being affected from generations and generations until, it was his turn to procreate. But now he happens to be in this day and age and he was able to go ahead and see me and do PGT-M and had a healthy baby. And I'll never forget what he said. I still get emotional when I think about it. He said, it ends with me.
Mm. Yeah, it is really powerful. I think for people who have such a strong family history, it is powerful to know that.
You have that power. Yeah.
And you're right, when that gene change is not passed on, then it can stop there. That person is now able to know that he can have a child or they can have a child that is not affected with that condition. And that child's children should not be at an increased risk for that condition either.
Yeah, it is pretty incredible when you think about it, to be the family member in your family tree that can just completely change the trajectory of your family story.
Another advantage of PGT-M testing is that it is highly accurate. So, of course, if we're using this testing to provide information for people about their embryos and the risks for their potential children, I think we want the testing to be highly accurate. Generally, the PGT-M testing is usually above 98% accurate. We know that there are always technical limitations. And for that reason, we offer and perhaps even recommend, I would say, that people consider using prenatal diagnosis or prenatal testing once they're in a pregnancy with those embryos that have had PGT-M testing. Certainly, that is a decision that everyone has to make for themselves. But PGT-M is, I would say, highly accurate, not 100% accurate. We do have tools available for prenatal testing if people are concerned about that small chance that the results might not be accurate. But generally, it's a highly accurate test.
Can we talk about the process of undergoing PGT-M? Let's say either you found out on your carrier testing or you do have a family history. What does that look like?
Absolutely. So again, it's really important. It's actually critical that genetic testing has been done to identify the genetic cause of the condition that's in the family. So if someone knows that there is a risk, that they've had genetic testing and they know what the chances are to have a child that's affected, they can seek out a referral to a fertility clinic. In that case, they would be, of course, meeting with the fertility doctor to talk about the IVF process. We need to have IVF in order to make those embryos that would be tested. Once a referral to a fertility clinic has been initiated, the patients would be meeting with a genetic counselor, either at the fertility clinic or through the PGT lab. With that, the genetic counselor is going to review their family history, review the genetic testing that's been completed in their family or in themselves. And sometimes it's important that samples are collected from the people who are having IVF, as well as maybe other family members who are affected or unaffected with the genetic condition. And so the PGT lab would sort of determine who they need samples from and what would be required in order to do PGT-M for that family. The PGT lab would then let the fertility clinic know that it's okay to proceed. So usually that happens once all of the required samples have been received. Then they would confirm that, yes, we can offer PGT-M to this family. From there, they would have the IVF to create embryos. Once the embryos are reaching blastocyst stage after usually day 5 or day 6 of growing in the lab, then the embryologist would be removing 5 or 6 cells from the outer part of the embryo. Those cells would be sent to the PGT lab for testing. And meanwhile, the embryos would be stored safely at the fertility clinic. And the PGT results are usually coming back in about, I would say, 3 to 4 weeks on average with PGT-M. We haven't talked so much about PGT-A yet today, but PGT-A can be completed on the same biopsy sample from each embryo. So when someone is considering PGT-M testing for their embryos for those very specific conditions, we would always offer the option to have PGT-A testing as well, to be looking at the chromosomes in the cells of the embryo, and again, putting both results together to help people have the highest chance of having a healthy pregnancy and healthy baby.
Can you give us like a quick little 2-minute refresher on PGT-A and when we use PGT-A and what the A stands for?
Yeah. PGT-A is standing for genetic testing for aneuploidy. Aneuploidy is referring to chromosomal abnormalities. And we know that when an embryo is created where there are chromosomal abnormalities, so an extra or missing chromosome within the cells, those embryos would have a much lower chance to implant and become a pregnancy, or a higher chance of miscarriage. And so we use PGT-A as part of an IVF cycle to test embryos for the chromosomes with the hopes of finding embryos that are PGT-A normal or have normal chromosome complement identified with PGT-A. We know that those embryos are then going to have the highest chance of implantation and ongoing pregnancy.
Just as a refresher, we did cover PGT-A on episode 30, so go back and check that out.
I think that it's really important to emphasize that PGT-A is something that we're probably offering to almost all patients who are undergoing IVF, that it's this kind of broad screening test to see what are the odds of success of an embryo working, sticking, and the risk of miscarriage, but that PGT-M is for a very specific patient population, for a relatively small group of patients, actually, I would say, who are coming to see us where we know that there's a specific condition that the children could be at risk of getting. How else do you distinguish between the two, or how do you counsel people when they ask around that stuff?
Yes, absolutely. It really comes back to the fact that in order for PGT-M to be sort of suitable or recommended for your IVF cycle, there needs to be a known risk or an identified genetic cause for a very specific genetic condition in either the person that's providing the egg or the sperm or within the family. And so, again, it's really in the context of a known genetic condition in that family. Most people who are having IVF, you're right, are not doing PGT-M.
We've talked a lot about PGT-M and how it's done and the utility of it. But what if there is a couple, let's say one of them is a known carrier of something, and they don't want to do IVF or they don't want to do PGT-M?
If that couple does not have a fertility issue, if they're able to conceive on their own, then they may not need fertility treatment. Many people might conceive on their own and would have genetic counseling to learn about the options that are available for prenatal diagnosis during their pregnancy. There are two diagnostic procedures. One is called chorionic villus sampling, or CVS for short. One is called amniocentesis. And these are procedures that can be completed to take a small sample from the pregnancy to do genetic testing for these very specific genetic conditions during the pregnancy. People can then learn whether their pregnancy is affected with the genetic condition or unaffected. These are options that would be available if people want to have that information during their pregnancy.
But I guess doing IVF, making those embryos, doing PGT-M is really the only way to have a very good idea of whether an embryo is going to be affected by a condition or not, right? That where patients can opt to proceed with embryos that are not affected as opposed to, CVS or amnio, where then patients will know if the child is affected or not, but then they're faced with a really challenging choice potentially in terms of what they want to do next.
That's right. At this time, PGT-M is really the only option that is available to test embryos, to know that you're transferring an embryo that's being tested, that to the best of our knowledge and ability, we know is going to result in a baby that is unaffected with that genetic condition. And so really the advantage is that couples and patients can move forward and transfer embryos knowing that there's a really high chance that their baby will be healthy and unaffected with that genetic condition.
And if you were confused by the term CVS or amniocentesis, do not worry. We've got you covered. We're going to be recording another episode with Diane because we cannot get enough of her about prenatal testing options in the future. So stay tuned for that.
So, what are the costs associated with it? And how does it fit into, in Ontario, our OHIP funded IVF cycles?
I would say I can give you some general costs. I would encourage everyone to speak with their very specific fertility clinics, but PGT-M testing is currently not covered by OHIP, even with our funded fertility program. The costs of PGT-M generally are an additional $6,000 to $10,000 per IVF cycle or to test embryos for those genetic conditions.
That 6 to 10,000, that would include the cost of creating the probe and the testing of the embryos. And then what about if they have to do a second cycle? How do the costs change?
Exactly. There are a couple of different PGT labs, and the pricing can vary with each lab. Sometimes the cost of PGT-M is for a set number of embryos. So, up to 8 embryos, for example. People might do more than one IVF cycle and can include testing for up to 8 embryos, even if those embryos are created in more than one IVF cycle. And then on the other hand, other PGT labs may allow you to do multiple IVF cycles to make embryos and sort of continue to do IVF cycles until you have as many embryos as you would like to have, and then go ahead with the PGT-M testing. So usually that fee is going to allow you to test hopefully many embryos and allow you to identify some embryos that are unaffected, some that are affected, and have hopefully the choice to select those embryos that are unaffected to then go ahead and transfer for a pregnancy. And we spoke before about the fact that PGT-A can be completed on the same embryo biopsies. And so usually all of those results would be reported at the same time. So you have not only PGT-M results for your embryos, but PGT-A results if that's something that you're opting into. And again, you would then ideally find embryos that are unaffected with the genetic condition. So PGT-M unaffected, and then also PGT-A euploid or normal. Those are the embryos that are going to allow you to hopefully have a child that's unaffected with that genetic condition and also unaffected with a chromosome condition and has the highest chance of a pregnancy.
As you said, these embryos are now potentially going to be going through 2 further levels of testing, PGT-M and potentially PGT-A. And so I think when we're talking about costs and budgeting, it's important to point out that for many patients who are going to be doing PGT-M cycles, it is very likely that they are going to need more than one IVF cycle because the pregnancy rates, let's say that we quote for an IVF cycle, the success rates are not going to necessarily be the same for a PGT-M case because these embryos have to go through a whole other level of testing to be able to be potential candidates for transfer. And the other thing that I see all the time with my patients in my practice anyways, though, even though we talk about what percentage of embryos are quote unquote should be affected and what percentage of embryos should be carriers and what percentage should be unaffected, somehow it never actually happens that way.
I think it's a really important point. I think you're absolutely right. People who are doing PGT-M I always want them to know that they very well may need more than one IVF cycle in order to find those embryos that are suitable for transfer, or both PGT-M and PGT-A unaffected and normal. And so, absolutely, I think there certainly is a chance. We expect that some of the embryos will be affected with the genetic condition. With an autosomal dominant condition, we know that each embryo has a half chance, a 50% chance to be affected with that genetic condition. And sometimes it happens that all of the embryos are unaffected, but it also sometimes happens the other way where all of the embryos are affected with that genetic condition. And so, part of our discussions prior to doing PGT-M is really to help people understand that they may need more than one IVF cycle. We want people to have reasonable and accurate expectations for their cycles, for sure.
I just want to clarify because we're talking about PGT-A and PGT-M and embryo biopsy. I want to clarify this because it comes up quite a bit that the embryos never ever leave MFC. It's only the biopsy, which is a little sample of cells that get tubed and get sent to a different laboratories for genetic testing. And then the report comes back and it let us know if the embryos are affected or unaffected, euploid or aneuploid or mosaic, but your precious, precious embryo never ever leaves the safety and the comfort of Markham Fertility Centre.
It's such a common question. You're right. The samples that are sent to the PGT lab, which is often international labs, the samples are traveling. Once the samples are received at the PGT lab, then the DNA is removed from the cells and amplified in order for the testing to happen. But you're right. It's so important to keep in mind that the embryos are safe and sound here at Markham Fertility, frozen in the embryology lab here at the clinic.
But in terms of PGT-A and PGT-M, can you talk about the sequence of events? So if somebody is, let's say they're 38 years old, they have been diagnosed with a condition, let's say they did carrier testing and they find that they have a condition that they need PGT-M for. Should PGT-A be done before PGT-N or PGT-M before PGT-A?
There's different options available depending on the genetic condition in question. And as you mentioned, sort of the age of the egg source. And that is important because we know that as the eggs are getting older, there's a higher chance for chromosomal aneuploidy or abnormal PGT-A results. Again, different labs will have different processes, but there is usually the option to have PGT-A and PGT-M sort of reported at the same time and results simultaneously, and PGT-A and PGT-M completed on all of the embryos. Some PGT labs will offer sequential testing that might be a little bit less expensive. And in that case, perhaps PGT-A would be completed first. And then for any embryos that were PGT-A abnormal or had chromosomal abnormalities, then testing may stop. And so the PGT-M testing would only be proceeding on those embryos that had normal PGT-A results.
PGT-M is wonderful technology. Like I said, it can really be a defining factor in a family history. And it is also very complex. Offering PGT-M to patients and our desire to help patients and to proper counsel them and give them good options is one of the reasons we're so happy to have three amazing genetic counselors working at Markham Fertility Centre, because with all of my training as a fertility specialist, I couldn't even come close to really understanding the nuance of PGT-M and, more importantly, being able to properly counsel patients about all these options. So thank you so much, Diane, for what you do and for helping us provide to patients that level of expertise. I think it's important to know that not all fertility clinics offer PGT-M. So if that's something that you're considering, make sure that you ask your fertility clinic. And the reason for this is it's different from PGT-A, and it requires a certain level of expertise. And some clinics do offer PGT-M, but they don't have in-house genetic counseling. It doesn't mean that you don't have access to genetic counseling. Some patients pay for it out of pocket to private genetic counseling. Sometimes the companies that are doing the genetic testing can offer genetic counseling. But I strongly believe that when you have a genetic counselor that is part of the team, that have access to the clinical information, who is part of the clinic, patients are better served, especially when we're talking about something as complex and as detailed as PGT-M.
Thanks again, Diane. We really appreciate it.
Thank you so much for having me. I'm so happy to be a part of this team and be able to support families who are considering PGT-M.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markhamfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.